Hello, I'm Dr. Ganapathy Prasad from the Barrett's Esophagus Unit at the Mayo Clinic in the Division of Gastroenterology and Hepatology. I'm here to present a video abstract on a paper which will be published in Clinical Gastroenterology and Hepatology titled The Safety of Endoscopic Mucosal Resection Before Radiofrequency Ablation in Patients with Barrett's Esophagus. As we know, radiofrequency ablation has emerged as a leading modality of ablation for dysplasia in patients with Barrett's esophagus. It is also known that endoscopic resection is often indicated in these patients to accurately diagnose the grade and stage of dysplasia. There have been concerns raised on the safety of radiofrequency ablation following EMR in these patients, especially widespread EMR, which may alter the stiffness of the esophagus and predispose to a higher rate of complications, such as strictures or even perforations. In this retrospective cohort study performed at Mayo Clinic, we aim to compare the outcomes of two cohorts of patients. Group 1 consisted of patients who received radiofrequency ablation after endoscopic resection. Group 2 received only radiofrequency ablation without preceding endoscopic resection. There were 44 patients in Group 1 and 46 patients in Group 2. Our primary outcome was complications from radiofrequency ablation in both groups, and these included stricture formation, perforations, and bleeds. The secondary outcome was histologic outcomes in terms of either complete remission of intestinal metaplasia, which I will shorten to CRIM, or complete remission of dysplasia, which I will shorten to CRD. Of the 90 patients in the study, all patients were managed identically in terms of receiving radiofrequency ablation in the standard manner, usually beginning with Halo 360 ablation and following with Halo 90 ablation. All patients had a mean interval of at least 3 months between radiofrequency ablation and EMR. Our main results were, number one, the stricture rate was 14% in Group 1, that is the group with RFA following EMR, and 9% in the group which only received RFA. This difference was not statistically significant. The rate of perforations or bleeds was similar, and in fact, neither group had a significant number with either complication. Our secondary outcomes included CRIM and CRD. CRIM was numerically lower in Group 1 compared to Group 2. However, when we adjusted for differences in baseline variables, including age, length of the Barrett segment, as well as the dysplasia grade, this difference disappeared. The rates of CRD were comparable between the two groups, averaging in the mid-70s. Hence, in this retrospective cohort study, we have shown that radiofrequency ablation following endoscopic resection, particularly in patients with dysplastic Barrett's, is as safe as radiofrequency ablation without endoscopic resection. I would like to add that this study is retrospective, the sample size is small, and results should be compared in larger prospective studies.